Today, what we're going to be doing is basically an overview of obsessive compulsive disorder. So, just kind of start out with, a description of kind of what OCD is, what does it look like, who has this, and kind of what do we know about it as a whole. Um, Much like many of what we now call mental disorders, we have good examples of people who today would be qualified as having this kind of problem throughout history. We have very well resourced sites and information about people like, for example, Michelangelo, who painted the Sistine Chapel, Martin Luther, who was responsible for kind of the schism in the Catholic Church that resulted in Protestantism. Even famous musicians like Beethoven, inventors like Nikola Tesla and Howard Hughes, and many other famous people throughout history who have had these OC symptoms. And then, of course, there's those millions and millions of folks who lived and died before we actually knew what this was, and just kind of had this and suffered. So this is not some sort of a modern problem or a modern disease. This is something that our species has definitely had for an extremely long time. Probably the most significant and influential conceptualization of OCD comes from the DSM, the Diagnostic and Statistical Manual of Mental Disorders. There were some pretty major changes from the fourth edition to the fifth edition, which came out in 2013. I'll be using fifth edition as it's the most updated kind of diagnostic information and demographic information. So an operational definition from the DSM-5 is that first, an individual has to have the presence of obsessions, compulsions, or both. This is one of those changes, the or both. It previously was just the, obsessions and compulsions had to be had, but does seem to be a subset of people who don't have identifiable compulsions or identifiable obsessions. They just seem to have one or the other. So the definition is broadened a little bit from the DSM-4 to 5. Now, what's an obsession? Well, we define that as having two pieces. One is that it's a recurrent or persistent thought, image, or an urge, an impulse that are experienced as intrusive and unwanted, right? So I'm not wanting to think about this. I'm not purposefully calling forth this thought. It's just intruding into my mind. I don't want it there, but it comes in there and then it causes me high levels of distress and anxiety. Now, most people actually have these kinds of intrusive thoughts at some point, but they just kind of dismiss them. In OCD, you have these thoughts, and then it's seen as being a very problematic thing. And so because it causes you the high levels of anxiety and distress, what you then do as someone with OCD is that you attempt to either ignore such thoughts, try and suppress those thoughts, try and get that image out of your head. In some way, you're trying to neutralize those thoughts, reduce your distress. And it turns out that's what we call a compulsion. Compulsions are those things that basically try to neutralize the distress you experience from having OCD. And these compulsions can be either repetitive behaviors that are observable to other people, or they can be mental acts that are not very observable. But regardless of what they are, the person who has OCD feels the sort of drive to perform these in a very rigid fashion, where I have to do this in a particular way. So, for example, I've washed my hands several times today. I didn't pay attention to exactly how long I washed them, how many squirts of soap I got them, or anything. I just washed my hands. Someone who has a hand washing compulsion, though, will often have a very rigid way that they do that, or a set amount of time that they do that. And they do that in response, not to just an external stimuli, but in response to an obsession, right? The obsession comes, causes me distress. I then have to apply a compulsion to get rid of that distress. And that's what the compulsions do. They try and reduce that distress or prevent something terrible from happening. Now, the difference in OCD is that these behaviors or these mental acts aren't actually connected in a realistic way with what they're supposed to prevent or neutralize. Or if they are, they're clearly very excessive. So before I had lunch today, I washed my hands before I prepared my meal. Now, that's what most of us would do, right? That's relatively normal thing to do. But how long did I wash my hands? I don't know, maybe 15, 20 seconds. I didn't count. Someone who has, concerns with hand washing and food contamination may spend a minute and a half or 2 minutes or 3 minutes washing their hands, which is clearly excessive. Um, we also see that, again, these things maybe aren't connected in a realistic way to what's actually going to happen. So I worry that if I step on a threshold, for example, something terrible will happen to my family, right? Something bad is going to happen to someone I know and I care for and I love if I do this or that act, which is not actually what happens. So that's what compulsions and obsessions are, right? So obsessions are these intrusive, unwanted thoughts that cause you distress. Compulsions are the actions you feel driven to undertake as a result of that distress, as a result of that compulsion. And then they then lower that anxiety or distress. In the DSM definition of OCD, these also need to be time consuming. So generally taking more than 1 hour a day, or they're causing clinically significant distress or high levels of impairment in functioning. And this could be social functioning. So I'm not seeing friends. I'm not interacting with my family as much, or I'm having high levels of conflict with my family. This could be work disruption, where it takes me 6 hours to do what it takes somebody else 2 hours because I'm constantly rechecking things, or academic disruption. So maybe when I'm taking a test, I feel the need to rewrite certain words in my answers until they're perfect. And that then slows me down and prevents me from actually going on to finish the exam, so I get a lower grade. So you have to have the obsessions, compulsions, or both. They have to be taking up at least an hour a day or causing distress and impairment. And then they're not due to the direct effects of consuming some sort of substance or some sort of general medical condition. And they're not restricted to the symptoms of another mental disorder, for example, hoarding disorder, body dysmorphia, or something like that. Now, one thing that the DSM-5 added that was not at all in the DSM-4 was specifiers. Most of those relate to insight. So in the DSM-5, you actually specify the level of insight that someone has into their OCD. This is important for treatment in a number of ways. So if you have good or fair insight, then you recognize that, yeah, these probably aren't true. They may not be true. I'm still going to do my compulsion, but they still may not be true. Those who have poor insight think that, yeah, it's more likely than not that my OCD beliefs are true. And those who have absent insight or who are delusional are completely convinced that they're true. There's no way that these kinds of thoughts are not true. So you specify the level of insight that someone has. And then you also specify whether or not they have tic-related OCD. So this is for people who have a lifetime history of a chronic tic disorder, whether that's chronic motor or vocal tics, or a combination of those, like Tourette's disorder. And that's important to specify also for some treatment, particularly for some medications that may or may not work as well. This gives you an idea about the most common kinds of obsessions that are out there that we encounter, as well as some examples of those. So for example, with contamination obsessions, where I worry that I'm going to be contaminated in some way, we see many people who are worried about germs and diseases, but also things like bodily fluids, blood or semen or spit or urine, dirt just in general, specific kinds of chemicals like household cleaners, bleach, for example, or environmental contaminants like radiation or asbestos or things like that. We see a very large number of religious obsessions in OCD as well. The most common kind of religious obsession is people worrying that they've blasphemed in some way or they've offended a god or gods in some way. We also see very high levels of concern about morality. Am I a good person? Have I done the right thing? Did I do something that's sinful or wrong, or in some way that's against what it is that I truly believe in? Those are very, very common kinds of obsessions. We also see superstitious ideas where people will, have an idea that if I do something a certain number of times, I'll have bad luck. If I wear a certain color, I'll have bad luck. I can't say a particular word. Those kinds of superstitious ideas. Perfectionism is a big one, where things need to be even, exact. They can't be off in some way, or not exactly what we need. Or feeling like I have to remember something, like I have to remember this or something terrible is going to happen. Or I can't forget something. I can't lose things in any way, shape, or form. Worries about harm or aggressive obsessions are very, very common. And that can either be, I'm worrying that I'm going to do something that will harm you inadvertently, like when I'm driving, maybe I have a motor accident or I hit someone's car, or I would harm you purposefully. When you're asleep, I go to the kitchen, I'm worried that I'm going to get a knife, come in and stab you with it, right? A lot of people worry about losing control in some way, fearing that they will act on an impulse, fear that they will offend other people with something that they say or a bodily noise or something like that. And then sexual obsessions are also very, very common. And these can involve a wide variety of things, typically things that are forbidden by a person's cultural background. So it's very common to have obsessions involving, for example, homosexuality and homosexual behaviors when you're heterosexual, right? So you experience this as disturbing. Or when you're homosexual, having heterosexual obsessions. Obsessions involving children, so pedophilic obsessions, or incest, specifically, children that you're related with are very, very common. Or obsessions about things like sexual assaults and rape. And it's important to understand that when you have OCD, these are not things that you want to do, right? The whole thing that just takes an obsession versus a regular thought is that obsessions cause distress, right? They're viewed as unwanted, intrusive, distress causing. So someone that you interact with who has, for example, pedophilic obsessions, when they have that, they don't get pleasure from it, right? It doesn't bring them pleasure or joy to have these kinds of images in their head. It brings them enormous, enormous amounts of distress. That's how you can distinguish something that's OCD from something that's not. Here are some of the more common kinds of compulsions. Checking compulsions are extremely common, and this could be that you check to make sure that you didn't harm someone. So maybe you feel a slight bump when you're driving, and you think, "Did I hit someone or something?" And so you then, go turn around, go drive back down the road to see if you actually did hit someone. Checking to make sure that you didn't offend someone. Are you sure? Are you sure we're still friends? Are you sure we're okay? That sort of thing. Checking to make that you didn't make a mistake in some way. So, for example, going over a report at work 15 to 20 to 30 times just to make sure that there's zero typos in it. Or checking to make sure that nothing terrible has happened. So checking the news to make sure that, nothing bad happened in the town that your best friend lives in or something. Repeating are very, very common compulsions as well. And this can be having to do things a certain number of times. I have to wash my hands 3 times, and I have to wash them 3 times for 30 seconds each. Having certain kinds of body movements where I have to maybe touch something a certain number of times, having to reread or rewrite material an excessive number of times. Washing and complete cleaning compulsions, particularly these tend to be related to those contamination obsessions. And this can be washing your hands, this could be cleaning, this could be excessive showering and bathing. This could even be something like excessively wiping after having a bowel movement. But in all instances, again, this is way outside of the norm. You also see a large number of mental compulsions. So this could be something like I have an unwanted, intrusive bad thought, so I have to cancel it out by having a good thought then. Maybe I count all my steps when I'm walking. Maybe I count how many times I do something in a particular task. We see lots of prayers that happen covertly. So you're not saying it out loud, but you're having a prayer covertly to, get rid of the blasphemy obsessions. So you can also see where you're collecting things due to compulsions. So I have to save this because something bad will happen if I don't. And this is way outside of I'm really interested in this or I'm a collector. This is something terrible will happen if I don't keep this thing. And then finally, we can see a large number of ordering and arranging compulsions. And this is where you have to make sure that all your books on your shelves are in a particular fashion. Things on your desk are a specific way. You've got to order everything around you until it feels right? And again, until it's recognized that this is the way that this needs to be. So kind of a note on some subtypes that we see of OCD. I mentioned earlier that the DSM has a specifier for tic-related OCD. We know that can account for a substantial portion of pediatric cases. So about 40% of all youth who have OCD have comorbid tics. There tend to be much more males than females in this category. And they tend to have slightly different kinds of symptom profiles than people who don't have tics. So folks with tics tend to have a large amount of symmetry. So things needing to be, lined up exactly. Or if I touch something with my left hand, I need to touch something with my right hand. Kind of ordering exactness. They seem to have a lot lower contamination issues. So it's not that you don't have it, but just the overall percentage is lower. And then you tend to have higher rates of comorbid trichotillomania, so compulsive hair pulling, and disruptive behavior disorders. So oppositional defiant disorder or ADHD tend to be very common in this population. With early onset OCD, meaning prior to adolescence, it looks basically the same as adolescent or adult onset OCD in terms of the nature of the symptoms, but it's dominated by males. Many more males have prepubertal onset of OCD than females, with a substantial number actually remitting by adulthood and no longer having symptoms. They do have very high risk of having tic-related OCD, so having comorbid motor and vocal tics, as well as comorbid hair pulling and trichotillomania. Now, when we talk about obsessive compulsive disorder, a lot of time we talk about the different kinds of symptoms or symptom clusters, or sometimes what we call symptom dimensions. And there's been a large amount of research over the last 30 years trying to see, exactly what kind of symptom dimensions are there in OCD. What are the ways that these look? How do these kinds of symptoms cluster together, in other words? And the research literature has some disagreement in there, because depending on the kind of statistical analysis that you use, you come up with slightly different numbers of dimensions. What has been pretty consistent, though, is that the dimensions appear to be temporally stable. What that means is that if someone has developed obsessive compulsive disorder with primarily contamination symptoms in their youth, if they continue to have OCD when they're older, they'll likely still have those contamination symptoms. Now, they may not be the exact kind of contamination worries. So maybe I started out being worried by dirt. Now I'm worried about bodily fluids or radiation or whatever. But the dimension appears to stay pretty consistent across time in almost all people. Now, this gives you an idea of kind of some of the different results that have been found from different kinds of studies. Most of the research that's out there has found either a 4 or a 5 factor dimension for OCD. The 4 factors break down into hoarding, so compulsively saving things, contamination obsessions with cleaning compulsions, concerns about symmetry and ordering, so you're having things the exact way, and then what we call forbidden thoughts, which would be things like sexual obsessions and religious obsessions. Um, some of the 5-factor analyses that have been found also add in a sense of over responsibility there. So, in other words, thinking that my actions have a much greater impact on my environment or on people's lives than they actually do. And then finally, our latent class analysis, which is a different kind of statistical analysis, says, well, it's not so much that these are different factors or dimensions, it's just kind of how many of them do you have and how severe are they? And again, that seems to be relatively stable across time unless you get treatment. This gives you an idea of the most common kinds of symptoms that we see in OCD. Checking is by far the most common kind of compulsion, with about 80% of individuals endorsing some type of checking behavior. And this could be, again, checking that my doors are locked. This could be checking that there aren't a contaminant on something. This could be checking that I haven't offended someone or that I haven't done something to hurt someone in some way. All sorts of different ways that can be manifested, but checking is definitely our most common. Hoarding is a pretty common one as well. As you can see there, well over half of people have that. Same thing with ordering, roughly 60-ish%. The next biggest are what we would consider those forbidden thoughts. So moral and sexual or religious kind of concerns, worrying that you have done something to offend the deity that you believe in, or that you've done something to offend your community and broken some sort of taboo there, or some sort of sexual or religious kind of obsession. So worried that you blasphemed, worried that you're going to assault someone sexually, things like that. Contamination shows up in about 25% of folks in terms of worries and fears about contamination. Worrying about harming is roughly the same amount, either harming yourself or someone else. And then illness worries or somatic sort of worries about contracting a disease, fairly low amounts. And then kind of all the other miscellaneous categories that you can see that fall in kind of round things out there. Now, prevalence-wise, OCD affects around 1% of our pediatric population, and it seems to be around 2 to 3% of the adult population. There's an additional 5% or so that would be considered subclinical cases, so you may still have obsessions and compulsions, but it's not for necessarily a long amount of time each day. And almost everyone who has OCD has both those obsessions and compulsions. There's something that people talk about called pure O, pure obsessional. And certainly, that happens, but a lot of times that can then be resolved and you can actually figure out what the compulsion is. And it's usually some type of avoidance kind of behavior. But most people have both the obsessions and the compulsions. The course, so how OCD naturally manifests, is usually gradual in nature. So it usually starts relatively low levels of distress, relatively low levels of compulsions, but it just builds over time due to the nature of how OCD works. And so what we see is typically a chronic and unremitting course if you don't get any treatment. Symptoms can change across time. What I'm worried about this year may not be the same thing I'm worried about next year, or what I'm checking right now is different from what I'm checking 6 months from now. But they rarely just disappear is the thing. Again, they tend to be temporally stable. So if I'm having sexual-based obsessions right now, I will probably continue to have sexual-based obsessions, even if the content changes a little bit across time. There are some gender differences, but primarily in youth. More males are diagnosed with OCD as youth, but by the time you reach adulthood, those numbers even out, where in adults with OCD, we don't see differences in the genders in terms of prevalence rates or numbers. We do see slightly different kinds of comorbidity patterns, um, where in men who have hoarding, which is again a very common OCD symptom, that's much more associated with things like generalized anxiety disorder or the tic disorders like Tourette's. But women who have hoarding based OCD, they're much more likely to have things like social anxiety, body focused repetitive behaviors like nail biting or skin picking, trauma in their past, as well as things like body dysmorphia. So we do see, some prevalence differences in terms of comorbids, even if the overall rates are roughly the same. And comorbidity is a very large concern in OCD, where about 75% of people who have OCD present with a comorbid disorder, especially, or this, I should say, this number is especially high in clinical settings, much, much higher than 75% in clinical settings. In children who have OCD, the most common are problems like ADHD, the disruptive behavior disorders like oppositional defiant disorder, depression, whether that's dysthymic or major depression, as well as other anxiety disorders. And what we know is that the presence of the comorbid problems actually predict the quality of life more so than the OCD severity, which makes sense when you think about it because you're just sort of piling symptoms one across the other. So the more of these symptoms that you have, the more difficulties you're going to have in your overall quality of life. In adults, the most prevalent comorbid problems are social anxiety, major depression, and then substance use. Alcohol abuse is a particularly common one, although we're starting to see an increase in things like marijuana abuse as well, as that becomes more legalized and more available in parts of the country. And we do, in adults, see that different primary obsessive compulsive symptoms are associated with different patterns of comorbidity. So, for example, if someone has symmetry and ordering symptoms, they're much more likely to have tic disorders, bipolar, obsessive compulsive personality disorder, panic symptoms, and agoraphobia. Somebody who has contamination and cleaning kinds of problems are more likely to have a comorbid eating disorder, whether that's anorexia or bulimia, while those who have hoarding symptoms are much more likely to have what we used to call the cluster C personality disorders. Things like avoidant personality disorder, depressive personality disorder, and so on. So the reason that that's important to know is because for you, when you're seeing, what kind of symptoms someone has, this gives you an idea about the most common kinds of other problems or difficulties they could be experiencing. So I need to, know those as well. Now, OCD, although it's kind of played for laughs in a lot of television and media, it certainly is a very problematic issue. Almost all adults and children who have OCD reports very high levels of distress as a result of it. Dr. Tindler just asked a question. What is somatic OCD typically comorbid with? Well, I don't have that here in the presentation exactly, but we see a lot of that being comorbid with body dysmorphia, as well as chronic sort of health anxiety. So worried about, am I catching a disease? Am I healthy? You see lots of going to the physician, getting unneeded medical tests and things like that when people have somatic OCD concerns. So almost all adults report distress. We see that a person with OCD's quality of life is very low compared to people who do not have OCD. In youth, we see problems with peer relationships and forming friendships. We see pretty consistent academic difficulties. And we see that those who participate or those who have OCD tend to participate in quite a bit fewer recreational activities, whether that's sports or robotics or church or whatever it would happen to be. So OCD definitely has a big impact on people's lives. Some of the research that has happened has shown that Although males and females in adulthood typically have roughly equal impairments, pediatric females tend to have a little bit lower quality of life. And that seems to be due to higher levels of depression and anxiety disorders there. One of the other things about OCD is that it's one of our more damaging anxiety or mood related problems, and that people who have OCD are actually much less likely to be married than those without, even with those who have other kinds of anxiety or depressive issues. They're more likely to be or underemployed, and they're much more likely to report impaired social functioning and occupational functioning. And again, this isn't compared just to people who don't have any mental health problems. This is compared to people who have other kinds of diagnosable problems like social anxiety, major depression, panic and agoraphobia, and so on. So OCD has a very large negative impact on people's lives, which is why we continue to work to try and find effective treatments for it. Culturally, we don't see a huge variation in the numbers of people who have OCD. And that's where you can see kind of here, this is, a top rate of a little under 3% and a bottom rate of, 0.5%. Most of our national studies show, again, here between, 1.5% to 3%, meaning that this is happening in a fairly consistent rate across cultures. And we also see that the types of symptoms, meaning those symptom dimensions that I talked about earlier, don't vary a lot. So you tend to see, again, these same 4 or 5 rough big clusters of kinds of OCD symptoms. What we do see, though, is we see different kinds of prevalence rates for different kinds of symptoms. So for example, here in the United States, people who have African American heritage are much more likely to show contamination issue than Caucasians or Hispanics, especially around animals. So being concerned about kinds of different bugs or animals contaminating them in some way. We see that religion actually plays a big role in the kind of expression that OCD takes, where Christians and Muslims who are very religious, they tend to have a lot more of OCD related to controlling their thoughts. So having, no impact or not having any impure thoughts or things like that. We also see very high levels of these religious obsessions in Jewish populations. In, for example, Orthodox Judaism, we tend to see higher levels of cleaning and kind of cleanliness-based obsessions and compulsions. So, again, your culture impacts how these symptoms are developed and how they appear, but not necessarily whether or not you actually have those symptoms, just kind of how they manifest.